in the spirit of self-organizing, I think I'm just going to introduce our own panel and we're going to get started. Keisha and I were just saying how nice it is not only to see so many people having turned out generally for an entire day talking about a lot of complex and maybe even weighty and sometimes hard things having to do with race and class and the economy, but also to have folks stay all the way through the end of the day. So kudos to you. I can promise a panel of amazing women talking about things that are really important. So as I think most of you know, I'm Felicia Wong. I run the Roosevelt Institute. I think what we're going to do, I'm going to actually just go ahead and introduce folks. And then we'll start right in on our health panel with the following question. I'll let you all think about this. But this is really, the last panel really was kind of econ in its more pure sense. This is economics having to do with wealth and income and how business works and the economy works and how politics intersects with all that. So the question I'm going to ask folks to really start with is, why would, Andrea, this is kind of for you, but why would in a book about the economy, why would we be including health? And then for all of you, how you think about health as related to social and economic well-being. But we'll get there in a second. First, let me introduce my fellow panelists. Keisha Bentley-Edwards is an assistant professor of medicine here at Duke and also is an associate director of research at the Cook Center with Sandy. And she looks at the ways in which cultural strengths can be used to promote resiliency and positive health outcomes, particularly for young people, kids, and young adults. Andrea Flynn is a fellow at the Roosevelt Institute. I have had the great good fortune of having worked with her for close to 5 years now, Andrea, and as co-author on the book that we're here to launch today. Sierra Zachary is a health policy analyst at North Carolina Justice Center's Health Advocacy Project. So she works, one of the many issues she works on is Medicaid expansion and reform. But again, we're really happy to have her here to talk about how all of this kind of research works in the advocacy world. And finally, Kristen Cooksey Stowers is a postdoctoral fellow at the Rudd Center for Food Policy and Obesity at the University of Connecticut. And she has a really, I think, evocative and important concept to talk to us about today, which is not food deserts, but food swamps. So I'm going to now actually start with Andrea on this question of why health in a book that's ostensibly about the economy, but then open it up to all the rest of you to talk about that as well. Great. Andrea.
Thanks. Hi, everyone. Thanks for sticking around for the last panel of the day. The earlier panel mentioned that a couple years ago, the Roosevelt Institute worked with Joe Stiglitz on a book called Rewriting the Rules of the American Economy. And as a part of that process, we had a multi-day roundtable discussion with a number of economists. And it was fascinating to me because those conversations ended and health hadn't come up once in those conversations. And I remember thinking that's so fascinating because I focus on health, and it seems so obvious to me that health is also an output of all these economic issues that we're talking about, but also in many ways an input. And so when we were writing this book, digging a little bit deeper into what the racial rules look like, we thought it was really important to specifically address the ways that the racialized rules of the economy lead to very different health outcomes for Americans based on where they sit at the intersection of race and also gender.
Great, thanks. I'm interested in how all of the rest of you also think about health as related to economics. So I don't know who wants to go next.
I'm happy to speak. Again, I work at the North Carolina Justice Center, and you saw the former panelist, Marian Johnson. So I've been hanging out with the Budget and Tax Center folks for too long. So I guess maybe I think about wealth and income and budgets a bit more. But also when we're talking about like the healthcare debate that took place this year, and thinking about how many people were able to finally access or be able to be covered because it was more financially accessible for them. And in North Carolina, when I work and meet with communities talking about Medicaid expansion, and you know that every year about 15,000 families experience medical debt because they're in the coverage gap, and they are facing, competing financial priorities of, putting gas in their car or food on their tables, or trying to even be healthy enough to be able to stay employed or get new employment, and seeing the economic and fiscal benefits to the state budget, but also what would happen to households and allow different communities to really contribute positively to the state economy.
Great, thanks. Keisha.
Well, one of the things I was thinking about is access to care, but also very simple things that may be an issue like co-pays. And so actually when you walk into the doctor's office and you have a copay, for some people it's $10 if you have a really lovely job. Typically if you're making a lot of money, you may not have any copay when you go in. But the less money you make, that higher that copay is. So it may be a percentage of the visit cost. And so even just the everyday, like, okay, I know I need something more than what I'm getting over the counter, and grandma's juju ain't working anymore. I need to go to the doctor's. That can be a budget buster. And that's not even talking about the medication that comes with it, and whether or not your prescription coverage is a copay, is a percentage, and things of that nature. So I think that as we think about health and income and just overall the economic issues, it's just the cost of being healthy, or even just the cost of care, are just so high for very basic levels. We're not talking about people that are that have major disorders or major diseases. We're just talking about, I've got to get this infection, taken care of, and I'll stop there.
Great. So actually, I'm going to turn it to you, Kristen. We use this metaphor of rules and hidden rules. I'm interested in how you think about the hidden rules of health, and in particular, the hidden rules of obesity.
Well, really quick, I wanted to comment on the last question on
great.
why health in a book on the economy. I think I view these questions from the perspective of food and nutrition, so at the very sort of basic, fundamental Maslow's hierarchy of needs. You can't do much in terms of labor market participation and political participation if you're sick and hungry. There's really great work being published on the topic of how our communities are designed for disease, right? So really, in my work in Connecticut, we're doing work in food pantries and thinking about how to mobilize those folks to address the immediate need of them being hungry, but also to mobilize efforts to do something about it. And so what do you mean? Would you mind saying that second question again?
No, so, I'm glad you said that, because I think that's a very important perspective. And I was also asking you how you think about the hidden rules of health, and in particular, the hidden rules of obesity, which is obviously much of what you work on.
Yeah, I really was impressed that in this book, the commentary on health focus a lot of on the community level, the structural level, rather than sort of individual processes. I sometimes get frustrated in the health space where there's a lot of sort of individual level interventions and small little nudges to get the person to go this way or that way. But I think that once those studies and interventions are done, people go back to their communities and they can't sustain the weight loss. They can't sustain the health. And so there's a community level issue that needs to be addressed. And so I was really happy to see the authors take on that issue of the importance of thinking about community level infrastructure, built environment. I thought that was really important. I also was really impressed to see the concept of food deserts raised in the chapter. I think though that the description of relative importance of healthy food to unhealthy food resources is closer to the notion of how we talk about food swamps than food deserts. The food desert measures and phenomenon only focuses on distance to a grocery store. And while that's important, what we're finding is that is not the root cause of the place-based health disparities that we care about. We care about food deserts for a lot of reasons, but if we're talking about obesity, diabetes, we need to be paying attention to the relative issue. It's not just what's there, what's not there, but what's there in place of it. One other thing that I think.
So say a little. So,
Yes.
so what's there is a food swamp. you're
What's
saying.
there is a
so
food
tell
swamp.
tell us what a food swamp is.
So a food swamp is an area where unhealthy food options inundate healthy options. And I think what's problematic, the Healthy Food Financing Initiative that is now sort of being pursued at the national level addresses putting a grocery store in low-income communities of color, irregardless of the presence of the gas stations with food, fast food, unhealthy food options that we know are heavy drivers of diet and choice. To follow up on one other hidden rule that I would have liked to see flushed out a little bit more in the chapter is the hidden rules of hunger. And again, what that means for labor market participation and health. Again, we can't do much if we're hungry. And we're seeing a lot of racial dynamics play out in the food assistance space, but also in the emergency food system space, so food pantries, soup kitchens. The evidence is there that the black and brown people are the main folks that are forced to go there. And so.
Thank you. Actually, Andrea, I'm going to turn this back to you now to give a little bit of a description of the chapter, which was primarily your research and your effort. What are some of the hidden rules generally, and of course, why do they matter?
Sure. So one of the things we wanted to show in this chapter, but also in the book more broadly, is that sometimes we think of causal pathways as going in one direction or in a straight line, and that the way we thought about this is much more like a web or a cycle, so that there are sort of pieces moving in different directions at all the time, and sort of being knitted together to produce unequal opportunities and outcomes. And so in this chapter, we focused on some pieces that you would think about automatically when you think about health. We talked about health coverage and sort of rules that create unequal access, like the failure of certain states to expand Medicaid, for example. We also showed how the Affordable Care Act was really beneficial in many ways. And then we talked about access to things like clean water, clean air, green spaces, healthy and affordable foods. We talked about the kind of care people receive, so that it's not only important to have access to care, but it's also important to have access to quality, affordable, and culturally competent care. And we illustrated many examples of how Black Americans, and particularly Black women, report experiencing a bias in the health system, and how that impacts their ability and desire to access care. And then,
can you say a little bit about what are some of the concrete rules that drive some of these disparities?
Sure. So I think one of the clearest rules is health coverage. And so
meaning insurance coverage.
Insurance, yes, sorry. So be that private insurance or Medicaid or falling into the marketplace, and that many states chose not to expand Medicaid. And what we saw is that in states that did expand Medicaid, the racial gap in health coverage closed pretty significantly, and in states that did not, there continues to be a large gap. And we were talking about targeted universalism earlier, and I think this is a really good present day policy that we can think about as targeted universalism that has helped close that coverage gap in important ways.
And it's targeted universalism because the expansion is for all, but its disproportionate benefits are for those who have had the least. Is that essentially?
Yes, exactly. And I think for me, my issue is specifically around gender. The benefits of Medicaid for low-income women, and particularly women of color, has been incredibly important. And In states that have some of the highest levels of maternal and infant mortality, states have failed to expand Medicaid. And we know that women who are on Medicaid tend to have much better health and pregnancy outcomes than women who are not. And so some states chose to expand, and I think we don't know yet what the outcomes are going to be in terms of maternal health outcomes, but we know that's a step in the right direction. And then there are states that made a choice to sort of keep that gap or the non-rule in place, and people are continuing to fall into this gap of not having care. And we know that that's going to be detrimental.
It could be health insurance coverage expansion, or it could be any one of a number of other rules. But how, since you work on Medicaid in particular, how is this playing out on the ground here in North Carolina?
So I would say this past long session in North Carolina was maybe the most hopeful a lot of the coverage gap enthusiasts have felt. And that's because there was HB 662, or Carolina Cares, and that was the first bill that was introduced by conservative lawmakers. And it's basically took 3 years for Republicans to finally maybe see some advantage to closing the gap. We know that the racial makeup of those who fall in the gap, it's probably 50% people of color and about 50% white. Most of the households are working, and we also know that most are women who are in the coverage gap here in North Carolina. One thing that that could be really harmful for folks that in the coverage gap, if the Carolina Cares bill, let's say, is successful in the next session, is that there are work requirements or increased cost sharing. And we know that that has been a trend that we've even seen on the federal level with wanting to block grant Medicaid, or other states in putting that drug testing. All of these are rules that would diminish, people's ability to finally access the care that they need.
Sorry, just because I think the audience is itself very diverse in its understanding of things like block granting. Can you actually break that down for us? What is
Sure.
block granting? Seems like giving states a whole lot of money, so isn't that good?
No. Just to put it plainly, well, the way Medicaid is now, it's a joint state and federal program, and that each state gets a match from the federal government. In North Carolina, it's about 67% from the federal government, and the rest is paid from the state. With a block grant would be a set amount of money that they would use a formula that's, as we know, the cost of health care increase, faster than what they would set the formula to grow. And it would not grow with the needs, like enrollment needs or the service needs of, the Medicaid population. And I think this was a key moment in why we were able to defeat many of the ACA repeal bills throughout the summer, is because states realize how financially dependent they are on Medicaid dollars. And I think also it helped remove the stigma of how many people that look like our lawmakers have Medicaid coverage, instead of what has been stigmatized as Black and brown folks with Medicaid coverage. But kind of losing my train of thought with Medicaid expansion, with this new administration in the White House, there has been letters that have been sent to states saying that they may be more willing to accept these barriers to people getting the Medicaid coverage they need. And we're seeing states start to maybe draft waivers or submit waivers to the federal government to approve things like work requirements and maybe higher cost sharing, or I forget the state, but drug testing. And we know that this, again, are just initiatives to stop Black people and other racial groups from getting health care and finally being healthy enough to maybe get a job and maybe fulfill that, the dream of pulling yourself up from your bootstraps, even though I don't think anyone really has bootstraps from the previous panel. So these are concerns that we're looking into in North Carolina if we're able to move forward with a broad policy change to extend coverage to most working adults or people who aren't even working but fall into that financial gap area.
Great. And go ahead, Andrea, and then I want to turn it to Keisha. Yeah.
Yeah, I just want to build on that a little bit, because I think this idea of adding really think about what it means to add a work requirement in order to get health insurance. Like, on a sort of like a very basic level, it just feels so wrong and also makes no sense, right? Like,
Well, especially because you have black unemployment rates in many neighborhoods at 35-40%.
Right.
Right, and you have nationally you have the black unemployment rate is double the white unemployment rate. So just there, that's a racial rule.
right, but also if you're not healthy and then you
Right.
cannot participate in the labor market. So it's so
And it's very difficult to get Social Security.
Right,
For
exactly.
health reasons.
And to piggyback off that, there's also the work requirements for food assistance. So you can't, you have to be working in most places, but you can't work too much, or, so it's,
Well, okay, I actually want to go to Keisha and talk about sort of the way the rules and then cultural beliefs can intersect. But before we go there, this focus on work, which you all have brought up, I'd love your thoughts on why in the world, for something as basic and, to use my colleague Derek's term from the previous panel, moral, as wanting people to be able to have access to health care when they are ill, and or preventative care before they become ill. Why in the world would we attach this to something like work? What do you think is going on politically? What do you think is going on? Why these work requirements for healthcare?
I think that it touches on a theme throughout the day, is that what I have has value as long as it's limited has limited access. So whether that's your schools, your type of work, your neighborhood, but also your doctors. If I have access to the best doctors in the country, do I really want you to also have access to the best doctors? You know how hard it is to get an appointment for the best doctors in the city? And then now, everybody's going to have access to the best? Oh, no. I have to wait 3 months for this appointment. How long is it going to be now? So certain basic things like that come into play when you think about people having to work. So setting up these barriers, that there are some self-interests that are involved. So yes, people may say there are philosophical ideas about, I had to work to get I get my health insurance through my work, so I don't understand why you can't also work to get your health insurance. You have to actually think about why people would not want you to have access to health care. Is that, especially when we talk about things like breast cancer. And so black women are dying at higher rates from breast cancer. And it's not just because, besides for when we're diagnosed, we tend to already have much more, a higher stage of cancer when we are
Later
at later diagnosis, and then having triple negative features as far as the genetic aspects of it. But then on top of that, even with Medicare, you can't always get access to the best doctors because they may not accept Medicare, or if you're uninsured, trying to get through any type of foundation to fund you or get you access to even basic clinical screenings is very difficult. And so I think you have to think about not just the philosophical reasons why people would not want people to have access, but actually the real tangible reasons as far as how
Going back to that zero-sum question,
that zero-sum question, yes.
So actually, I want to turn to this culture question, and then we can come back to, I think, Andrew, you want to say something, but I did want to, your work is particularly on questions of cultural beliefs, self-image, et cetera, and how do those elements or drivers relate to the rules, which are more about policy and access and, lawmaking? How do these things intersect for you in positive or negative health outcomes?
Well, there's a few things just some basic things that I feel we should get on the table. What is health? How do you know when you're healthy? And if I ask everyone in the room, how do you know when you're healthy? You're going to think about it in very different ways. How do you know when you're healthy? And that's going to be driven by race. It's going to be driven by class. How do you get healthy? What do you do to stay healthy? The green space, I love that you talked about systemic issues and neighborhood access to space and safe spaces. Can my children go outside and play in the park? Is the park for adults or is it for children? Those types of things that come into play. But even when it comes to how do I know when I'm healthy? If you ask a poor person, how do they know when they're healthy? It's when I feel good enough to work, right? If you ask someone who is wealthier, how do I know if I'm healthy? It's because I can run the 10K, right? So it's very different ways of looking at how do I know when I'm healthy. And so when you think about that, about how the way that you interact with doctors and they ask you, how's your health going? If you're not asking very specific questions in the doctor's office, it could go in a lot of different ways.
And this gets back to what Andrea was hinting at with culturally competent care.
Absolutely. And so thinking about the culturally competent care, oftentimes, I'm a psychologist. I'm in the med school, I'm a psychologist, so please don't show me like open source on the way out. But a common concept that we talk about in psychology is cultural mistrust. And Black people not trusting their doctors, not trusting their psychologists. And a recent poll from Robert Wood Johnson came out a few days ago showing that over 30% of African Americans say that they face discrimination at the doctor's office or in with their healthcare provider. And because of that, 20% say that either they or their family member have avoided care. And so with cultural mistrust, this concept of cultural mistrust is that Black patients do not trust doctors. And the issue I have with that is that oftentimes it's tackled as, well, we have to change the way that African Americans view doctors in the healthcare system without actually saying, what do we need to do in the healthcare system to make us more trustworthy? And actually looking at the systems and barriers that are in place that are creating barriers to care. Because when you are sick, the last thing you want to have to deal with is somebody questioning whether or not you are sick. You know, so, and especially having to deal with health insurance companies. When my mother was sick, I remember my dad had basically spent at least an hour to 2 hours a week talking to health insurance companies because he could and my mother could not. But you're expected to know how to navigate these systems. And if you don't, then you're looked at as not really caring about your health. And I think that that's where the intersection of race and class and gender come into play, because women are expected to be more health conscious than men, and women are expected to know how to work these systems. But if the system is not necessarily set up for you to be successful in your health, in your journey towards health, then you have to actually talk about the system.
Thank you. It's very helpful. Andrea, did you want to add something to
I was just
that?
gonna
And then it looks like Kristen has a...
Go ahead.
You know
Go
what,
ahead,
you
and
should
then-
go, because I was going to say something about why work.
All right,
So
well,
you should.
Yeah, I wanted to piggyback off of something Keisha said about asking the right questions in the healthcare space. Again, I'm coming at these questions from the standpoint of food and nutrition. But what we're seeing is a big push for doctors to be asking about access to food and food security when they're prescribing medicine, right? So, part of what perpetuates mistrust is if I tell you I'm having an issue, maybe complying to the instructions that you gave me for my medicine, and you jot down that I was non-compliant, but I was non-compliant because it says take with food and I don't have food, right? And so people, a lot of the people that are coming into the emergency food system come into the system sick. And so you have that issue in the healthcare space, and then you go to the pantry that is not able to give me food to help me meet the requirements of what my doctor told me to do, or are making me sicker, right? So if I am coming as a diabetic, the fact that you give me a half-sheet cake to go along my merry way is problematic. And I was actually in a food pantry where a client went into a diabetic shock, and they roll their eyes, and she does this every time she's here, and put her back in the line for a half-sheet cake, right? So just to really sort of, put that on the table.
Okay, thank you. Let's see. Why don't we go, Andrew, you had a comment about the why work, question, and then I might actually turn it to, solutions, or like how do we get to a more positive vision? But why don't you say a little bit about the work requirements phenomenon?
Yeah, I was just thinking that earlier today, or maybe it was on our radio thing earlier today, but we talked about how a lot of this book is about who belongs and who doesn't belong. And I think this idea about, requiring certain tests or work requirements in order to receive public goods says a lot about who we believe should, belong, or who should have access to certain things that should be public goods that we should all have access to. Derek Hamilton's recent paper talks about the politics of personal responsibility, and this feels very much connected to that idea, and just how harmful that idea can be, and how harmful it can be to sort of not only in shaping neoliberal economic policies that themselves have negative health outcomes, but also in sort of creating this culture of stigma and stress that impacts individuals on a very cellular body level. And so just thinking about sort of, there are these economic impacts, and then there are the ways that this kind of conversation creates a cultural environment that is itself very harmful.
Thank you. Okay. Now I want to turn to the question of, you collectively have laid out a vision of a politics and a healthcare system that has shrinking coverage, poor access to care, poor access to culturally competent care, very little access to food that is healthy, and overall a kind of blame the victim, why don't they work harder ethos. So none of that sounds optimistic. But for each of you, what are some of the very tangible things you think we can do to begin to reverse this trend? And any of you can, it's not a trend, but to reverse this, to begin to kind of beat back all of these systemic elements. That's really what it is. Any of you can go first in terms of policies and or political actions that you think we can take that would be effective.
I'll start. At the Justice Center, again, one of our main strategies is community education and engagement, and we do go into what North Carolina calls the Tier 1 counties, or counties that may be more, economically disenfranchised or fragile. And I think that was and even when we look in the broader federal debate about healthcare coverage, what was so key was getting all the voices out there, people telling their stories, calling their senators, their congressmen. And I think that is something that we have to do here in North Carolina. In North Carolina, we're also in the phase of Medicaid reform. This is a great opportunity to build up community voices to say, when you talk about stakeholder engagement, about talking about changing the way Medicaid and how I can access Medicaid, why don't you have any beneficiaries on your medical advisory board? Getting community members to come out to our public hearings when the secretary of our Department of Health and Human Services say, when you talk about social determinants of health, to me, social determinants of health means you need to give me childcare and transportation so that I get to, my doctor's appointment, so that I can keep the job that you're saying that I need in order to even get my health coverage. So I think that is one of our major strategies during this Medicaid transformation, is really putting what we call the consumer voice back in there and advocating for more funding to talk about and have an ombudsman program so that we can hold managed care companies or whoever's distributing this care accountable, and how are we going to be transparent in evaluating the care, and is it closing any kind of health disparities gaps?
So, organize,
Yep.
to quote Dorian Warren. Kristen, what positive policies or politics would you put out there?
Yeah, I would piggyback off of the sentiment around organizing and more inclusive decision-making processes. I was in terms of the hidden rules outlined in the chapter, I was most struck by the racial residential segregation one. I think that is a really important one to reflect on. I can compare it most to, in terms of the implications of that, it's almost like a checkerboard. It makes it easy to pinpoint spaces to suck dry health promoting things, grocery stores, all the good stuff, right? And simultaneously add in health restricting things. So you have it from both ends, right, to make sure that we're sick, we can't mobilize, we can't educate ourselves, we can't work. And so I think one of the most immediate things is to make sure that the folks at the table in the room deciding what our communities look like are reflective of the community, that the folks that are impacted the most have a say-so on what's on how that community is designed.
Thanks. Keisha, any thoughts on this one?
Well, my main thing right now is thinking about the training of doctors and having multicultural education and diversity training not be a 1.5 hour session at the beginning of your time in medical school, and then also that it's part of the continuing education in a meaningful way beyond a 1.5 hour session. I think that that's one way to make it a bit more meaningful and to have some accountability as well, accountability measures that come into play.
Great, thanks. Andrea.
Yeah, so I have a couple. One is, I think, we talked a little bit about bias inside the medical system, and that to me feels like something you could actually take on, right, in this like hard environment where big policies are feeling really hard, that actually like working inside organizations and hospitals to do trainings and elevate awareness around what bias exists, how it impacts people, that feels like something that could move the needle a little bit in an important way. I think that keeping health in the conversation in economic spaces, which is not, I think, is natural for us who focus on economics, but thinking about how issues that don't always get lumped into that economic bucket, and I mean the full range of health, not just sort of this stuff that's easy to talk about, but abortion, trans care, family planning, right? These issues that are politically sticky, they feel politically dangerous. They are also more under attack now than ever before, that now is the time to bring those issues and conversations into spaces where they might not feel comfortable or common. And so I think it's all of our jobs to sort of talk about like what social issues do we not are also economic issues and we don't always think about that way, and how can we bring them into spaces where we might not
Andrea,
be
how
talking
in
about them.
particular is reproductive care an economic issue?
So I mean, there are a few ways. One is how can we be expected to sort of participate in the world and in the workforce if we can't make decisions about our bodies, particularly about the timing and size of our families, but also about our healthcare more broadly. I would say there is some new research that's come out from a study called the Turnaway Study that shows how much more likely women who access abortion and are turned away are, how much more likely they are to land in poverty than women who seek out abortion and are not able to access it. And we already know that women who seek out abortion are already more likely to be in poverty and have access to care. So there are a number of ways that reproductive health care is an economic issue, but I think this issue of abortion access and the ability to plan the timing and size of our families is really critical.
Thank you. Okay, I have one more question for not really a table, but for the panel. And then I'm going to turn it over to the audience for any Q&A. And so, a lot of what we've talked about here is, not only on this panel, but throughout the day, has been the importance of organizing, often at a local level. That makes a lot of sense. But I have to ask you all, do you have any hope for our national politics now? And if so, what is it? Or the converse way to ask that is, what do you think is the most toxic part of our national politics when it comes to the way we talk about the economy, but in particular health?
Well, thinking about reproductive rights, conversation my husband's in the audience, we always talk about is that there's this war on women actually having sex. And that when you talk about reproductive rights, it's never about just being able to have sex. If you're fighting like, well, women use birth control for so many different things, and which is important, but also to control their families so that they can have full lives. I think that's and also part of our rights. And I think that that's something that
we need to grapple with on
we
a
need,
national level.
we need to grapple with on a national level. And it's like, okay, so you're not going to pay for birth control. You're not going to pay for maternity care. You're not going to pay for child care. So clearly what you're saying is that I just need to shut up, be quiet, and close my legs. Like that's, because there's nothing, and that's just not realistic because we know that the politicians are having sex.
Yes, they do.
So, and so those are that's the thing that I feel is frustrating.
National politics. Anybody else want to comment?
I do think that, in this, the incredible attacks on Planned Parenthood over the past couple of years, like Planned Parenthood is an incredibly popular organization, and I do think that I don't have like a ton of hope in this moment, but I do feel like slightly hopeful that there actually has been a ton of mobilization around women's access to healthcare, and that people who now have it are like, hold on, I'm going to lose my birth control coverage, right? There does seem to be this like energy and momentum around that issue, and so I do feel a little hopeful that there's more mobilization around that than there used to be.
Any other comments about the national scene?
I mean, I think collectively a lot of people breathed a sigh of relief on September 30th once we figured out that for this fiscal year there were no more attempts, or could be no more attempts, to outright repeal the Affordable Care Act and try to dismantle Medicaid. However, I do think we know that there are more threats happening now, but I think as people become more aware of how important their health care is and are holding their elected officials more accountable, it's going to put conservative lawmakers who want to erase Obamacare, hold them accountable, because they are kind of in a little identity crisis. They want to help their constituents, but at the same time, they're like, oh, I don't want to support a bill that was enacted by a black president. And I think the more that we get folks on board of sharing their stories and keep them knocking on the doors of their congressperson, the more I think we show how invaluable the ACA and Medicaid is. So that makes me hopeful in believing in the collective voice of folks.
I guess I'm less hopeful. I think the national discussions around sort of immigration and citizenship, I think we're talking about mobilization, we're talking about inclusion. I feel like in the diet-related disease space, we have concern that the folks that were relying on food assistance and relying on food pantries prior to Trump coming into office aren't showing up as much anymore. So there's a fear of showing up at the pantry and you get deported. And so not to sort of take away the hope that's been, posed, but to think about, more creative ways that we might do that, because, the fear of mobilizing and being identified and being deported, it's a real one, right? And the other thing I'll say, as I think about segregation and what that means for our access to food, there's sort of an interplay of a national sort of media as gatekeepers, both at the national level and more local level. Specifically in the fast food space, we see access to zoning decisions preserved for white privileged neighborhoods, and the examples that we have where Black and brown communities have tried to take on fast food and kick them out, they have ultimately been dismantled by the way the issue was framed in the media. When it's in a white privileged neighborhood in California, this is to preserve the local aesthetic and to preserve the local charm. When you take on fast food in South LA, this is the government slapping cheeseburgers out of Black and brown people's hands, and we know that paternalism turns people off, right? So why would we frame debates in that way, but to discourage and dismantle? So I am wholeheartedly excited and enthusiastic about the thought of inclusion and mobilizing, but I think the fear of immigration and media as gatekeepers are things to keep in mind.
I totally agree. I will take the moderator's prerogative and throw out one thing that I am modestly hopeful about and then turn it to the floor. this might seem like a very odd thing to say in the wake of an election where a woman won but then lost. But I am actually very hopeful at the most senior levels of our politics, and particularly in the Senate, at the wave of really smart, strong, effective women members, female members of Congress. And I say this, across the board, both Democrats and Republicans. I do actually believe that part of the crisis we're seeing now is a crisis of a very, at the risk of being gendered, a very male-centric way of thinking. I think most of the women that I either have met or read about, whether it's on the Democratic or the Republican side, whether it's Elizabeth Warren, Kirsten Gillibrand, Kathleen Cortez Masto, or Susan Collins, or even Lisa Murkowski, people whose politics I might not share. The one thing I think about these women is that they will get things done, they will solve problems, and they will look at them holistically. And I think they would understand much more than other politicians whom I have known or seen or worked with. They will understand this continuum from economic and sort of, from economic issues to health and other well-being issues. So I have some level of hope that more women are in places where they can get more done. I think that is a small amount of hope, but I do think it is something. Anyway, let me turn it to just the audience. Do people have questions for the panel about health?
Everyone's ready for
No
drink.
questions? Yes, we have a question. We have two questions. One, two, yes. Mic one, mic two.
Should I go first?
Yes.
I feel like I've hogged most of the day. That's why.
That's okay.
But I'm YM for folks who didn't already know that. And I guess I, as a African American and an African American who's gender nonconforming, who identifies on the trans spectrum, I've personally struggled a lot with accessing healthcare. And I've always been, for the most part, since I was an adult, an uninsured person. So. I guess my question, like we talk about doctors labeling people, like particularly black folks, black women, poor black folks, black LGBTQ people is medically non-compliant, and I worry about that as a lot as someone who does try to advocate for myself at the doctor's office, but I also having to educate people about LGBTQ stuff,
Right.
Having to push back on people's like racist assumptions. I've had to do that since I was a kid. Because they always assume as a black female assigned kid, black girl, that you are sexually active and want to have are having babies. That's always their assumption. So I always had to deal with that misogyny as a kid. So I guess how can we advocate for ourselves as the doctor when even in our own self-advocacy, they're probably labeling us non-compliant behind the scenes. Like how can we effectively do that as people from marginalized communities?
Do you wanna-
I guess is my question to the panel.
Unfortunately, you have to do a lot of research on your own to know what it is that you need, and you have to doctor shop. And I think that is something that I think because when we go to the doctors, you have this one-on-one time. We feel like we have to stay with them, or we have this record of care, but you can go somewhere else. And I think that also is power in and of itself. And actually calling your insurance company, and especially if you're using a healthcare system, like in California, you have Kaiser, to actually say this is what I need, and to hire people who can serve my needs. I think that's part of it. But you can't control what people are going to think, but you just got to keep fighting for yourself. There's no easy answer to that. I wish there were.
Andrea.
Also, just to bring it back to the rules conversation, I think, I think about how important public care options are. And when we think about Medicaid funding for Planned Parenthood, when we think about the Title X network and Title X funding, which has been under attack now for a long time, and one of Donald Trump's first pieces of action when he became president was to change the Title X rule that Obama put in place, which means that states can now funnel all of their federal family planning money to anti-choice organizations like crisis pregnancy centers. But these facilities are not only important because they're public, but also because they have a very high training requirement. And so the individuals who work there are required to have speak multiple languages. They know how to work with youth. They know how to work with the LGBTQ population. So these are services that are really unique to public facilities and that are under threat. So I think it's important to just remember how important that is in this conversation.
So you're saying that public goods are actually public.
Yeah.
Yes. And there was one more thing, and actually thinking about my colleague Selena Alamin's work, is self-disclosure is important. You can't assume that doctors are going to either know or ask you about your gender identity or your sexual orientation. And if they know, they can offer better care as far as these are the we know that you have this risk, or this population may have that risk, or I know to ask you if you're engaging in this behavior and that behavior, or just in general know that oftentimes you don't get a chance to you don't get to go to the doctors because you don't have the work protections. So here we go back to work.
Yeah.
When it in this state, in most states, in the South particularly, so getting back to work and having health care. So actually disclosing your identity and your orientation to your doctors is something that is helpful.
Well, I struggle
And a battle.
with disclosure precisely because, like, I do disclose, and it's dealing with their ignorance is part of the problem.
Absolutely, because you have 15 minutes with the doctors, and then you have to spend 7 minutes educating them.
Right.
So,
We've got
On a local
couple
level, I would
questions.
just recommend
sorry.
contacting Equality NC. They have a
Yes.
great policy analyst, Ames Simmons, and he's really great about the LGBT and trans issues and policy, especially how it relates to the ACA and Medicaid.
Great. We have a couple questions over here. Yes,
First of
sorry,
all-
yes. Hi.
First of all, I guess on a personal note, I had a primary care doctor send me to a specialist, and the specialist prescribed a shot for me every 2 months, but the specialist copay is $94. I said, I can count, and that's crazy. So then I said, do you have to give me this shot? I just kept badgering. And then finally they said, no, because the nurse there was giving you the shot, not the specialist OB. And so I said, well, I just send my prescription to the Harris Teeter on MLK. So then they would now, every 2 months, they send the prescription there, very cheap. I take it back to my primary, have no copay because it's not a doctor visit, it's just a nurse visit. So I've totally figured out a way to get around that. It's just a matter of, they're not smarter than me. Actually, I figured that out.
that's very true.
And on a professional note, I'm a journalist focusing on community health centers and how, they seem to be closing. I just wonder if someone has a good update on the status of community health centers, because people haven't talked about it much. They keep talking about CHIP and the funding for the Children's Health Insurance Plan, but all that was tied together when funding wasn't improved. I'm just wondering, because I know.
Community health centers? Anybody?
Yeah, so the cliff is real. And what we think is going to happen is that the CHIP Community Health Center funding is just going to get lumped into one global bill before the end of the year. That's really unfortunate, especially when we think about our CHCs. I think 43% of the population they see is uninsured. But that is a really important topic, and they are struggling. They're making decisions now to have hiring freezes. Are they going to lay off people? But we're hopeful.
Can I just, one other, the conversation around defunding Planned Parenthood and other reproductive health centers often goes something like, we don't need them anymore because we can just have community health centers provide all the care. And so the answer is, like, even if community health centers didn't go anywhere, they still couldn't. But this argument comes up a lot, and oh, we can do this because it exists over here, and then while they're trying to deplete all the funding for that thing.
Terrific. We've got 3 more questions, and then I think we're going to go ahead and wrap it up for the afternoon. But yes, right here.
Hi,
Hi there.
my name is Tia Hall. I have one question, and then I want to lift up a couple of things. First, the role of dental care in our overall health, and how do you see that playing in line with race? I have a lot of thoughts on that. The other thing that I want to talk about, Ms. Wong, you mentioned obesity, and how does that play out culturally, and I think about the penalty that we receive culturally. So blaming people like there's an obesity tax, right? Instead of looking at the generational trauma that we experience, especially I'm thinking of as Black women, like how does that just exist in this conversation? And as I wholeheartedly believe in women's right to choose and embracing our reproductive rights, I also think about reproductive justice. And as Black women in this country, the justice and the ability to reproduce absent state-sanctioned violence is almost non-existent. To have that freedom, so something to think about.
You know what I actually like to do, just to make sure that we, honor time. Well, I'm going to ask all 3 questions, and then have the panels do one final wrap up, so we can answer all the questions at once. Yes. Hi.
Hi. Thank you. I'm a 3rd-year doctoral student in the School of Nursing here. And I am doing research where I interviewed African Americans this past summer and talked to them about health. And one of the questions I asked was, what could help you be healthier? If you could have anything in the world, what would you need to be healthier? And most of the people that I talked to, they said, I just need a little extra motivation. I need something to help me put down that bag of potato chips or get up in the morning, especially when it's cold, and go out and do my walking. I think only one person actually said, organic food is really expensive. So my question is, how do you work with community members and meet them kind of where they are when you're seeing barriers, but they actually are seeing that they feel like they have some agency, some hope, some control over how they can improve their health?
Thank you. Last question.
This goes off what you, Felicia, said a little bit about the senators, female senators. With the increase in women going into medical school, more than men now, and the increase in nurse practitioners, predominantly female, in our healthcare system, do you think we'll see a shift in power and like the power of knowledge, giving the power of knowledge to the patients, and any hope in a universal healthcare system with more women going into medicine?
Okay, so we have thank you. We have a range of questions from sort of the role of women in the healthcare system, whether in decision-making roles or other civic engagement roles, which I didn't even talk about, but like many, many more women are just politically active in the last year, or women in roles as healthcare providers. Then we had a set of questions around more questions around obesity. We had a question about dentistry as it relates to all of the health access, especially because I think insurance for dentistry is there's a different cost payment system there, entirely different. And then finally, this question about agency and motivation. So we've got a lot of questions. We've got a lot of people to answer. I'll let you kind of take your pick, and then we'll wrap it up. Andrea, you want to go first?
Sure, I'll go first. I just want to the reproductive justice comment, I just want to say I totally agree. I think that's one of the reasons we chose to focus on so many different pieces in this book, is because we acknowledge that just having access to one set of services doesn't mean it's going to make you safer or more economically secure. And so, yes, family planning access and abortion access is critical, but not without the ability for women to have healthy pregnancies and healthy babies, for their kids to be safe on the streets. And so I'd just say that intersection of health and safety and economic security is critical, and you can't untie one of those from the others.
Thank you. All right, final thoughts on any of those issues from, I'll just go in order, Keisha, Sierra, Kristen.
I think dental care is a big issue, similar to what we were saying about the different structures. But a particular concern is thinking about diabetes, and oftentimes people don't realize that being diabetic puts you at a higher risk for gingivitis and other gum disease disorders. And so that's something that, as we educate people about, our bodies is a system and it's all connected. And so as we think about these disparities, that dental care is in fact a big a big concern, and it's not just it's if you're losing your teeth because of your sugar, you have to deal with your sugar, then you have to deal with the aesthetic because getting dental implants or getting dentures, are very expensive and may or may not be covered, especially if you're just getting a partial.
Right.
So those are things to consider, and that's where we start talking about, can you get a job?
Sarah.
So dentistry, I hear this all the time when going into communities talking about healthcare. They want dental care for just the self-esteem of wanting to get the job so that they can be healthier and have access to care. And another reason to try to protect our Medicaid program on the state level, it's optional for many states. They can choose to offer dental care. So again, is North Carolina choosing to make sure that people's oral health is just as important as physical and behavioral health, especially as we're transforming Medicaid. In regards to the universal health care, I'm all about it. I think right now, after this recent big debate in the federal level, maybe the people willing to risk their capital or their clout on the Hill is a little bit, uncertain, but we do know that Bernie Sanders and some folks did introduce a bill, and I think it's really important for us to keep on pushing towards this goal, even if we still have 19 states that need to close the coverage gap. So I think as more states get closer to having lower uninsured rates, people will start seeing the benefits, and maybe one day we'll get that universal coverage.
Kristen.
So I was happy that the issue of oral care was raised. This has come up again in the context of emergency food. We did interviews with food pantry directors about the potential impacts of doing some nutritional work in this setting and sort of debunking some of the stereotypes about communities of color not wanting fresh produce or the poor not wanting fresh produce. And someone simply said they can't chew the food. I mean, this is not that their clientele has more folks that have lost their teeth than folks that are doing nutritional intervention work in other settings. So something to be cognizant about, right? To not go straight to people don't want it, blaming the victim, but to think about these cumulative barriers, right? Because these fresh produce, you need to be able to chew fresh produce. The point about obesity and agency, I think what's really important is to point out to folks that humans are especially prone to high-fat, high-sugar food products. That's all of us, right? So you individually don't feel bad that it's hard to say no to the chips. The studies show that we all kind of are, right? So the studies looking at our brain when folks consume potato chips, fried foods, shows it going off as if we were consuming heroin. So that's sort of everyone, right? And that's true. The reward dynamics in our brain function the same as if we were consuming drugs. Okay, so this is not. It's not you, right? But to show people that, so sort of to normalize the food swamp effect, right? It wasn't until I went away to college and came out of the food swamp environment in Chicago and saw that all folks don't live like this. All folks don't at every turn have to say no to the KFC, no to the Taco Bell, no to so to point out structurally that your environment is designed for disease. At every turn you have to sort of contradict, you have to counteract what the community, the environment is telling you to do in terms of your behaviors. And I think that seeing that lack of fairness to show people that there are communities in California that is designed for them to make all the right choices really gets people worked up, and that's where you mobilize and that's where you focus on the agency.
Thank you. And I will just close by saying, with respect to the gender question, that I too think, yet again, that as more women go into positions of expertise and authority in health and the economy and all other areas, I do believe in the long term that is what is one of the very important things that will drive positive change. So thank you for that question.